Let me stop here and hopefully I've entertained you if nothing else. But if you do have any questions, I'll be happy to try to address them.
Thank you, Stephen. That was a thorough and great presentation. Um, I will ask anyone who has questions to go ahead and put them forward.
Hi, this is Ibrahim. I just wanted his thoughts about um, addressing the performance disparities with modern ventilators that are in use. Um, a lot of neonatologists in practice try to treat all ventilators the same way, when in fact the hardware and the algorithms underneath vary quite differently. And nobody wants to say that, a particular ventilator is bad, right? At what point do we join, other industries, where you look at car manufacturers, you've got performance data that's out there. You look at computers, hardware, you've got performance data out there. When it comes to ventilators, the data out there is quite scant, especially like with performance in relation to leak compensation, trigger delays, synchrony, asynchrony indices, and all that.
Yeah, I think it goes even one step further than that. It's terminology. This is one of my pet peeves with the industry. And I've written about this and spoken at length. I think that my fondest wish is to get representatives from all the manufacturers, put them in a conference room, I guess with masks and 6 feet apart, but not let them out until they agree that nomenclature and terminology is going to be standardized. But you're absolutely right. And I think the problem is that there is a divergence between science and medicine on one hand and economics and industry on the other. And everybody is looking for a gimmick, why you should buy their ventilator and not the other guys. And I think as a neonatologist and pediatrician, I can give you a really interesting sidelight on this. And that is, when we had the first generation of multimodal devices, and I can speak at length to the Bird VIP and the Bird VIP Gold ventilators, because these were pediatric and neonatal specific devices. And they were designed with the peculiar needs of this population in mind. But suddenly, the manufacturers wanted to go to a single platform that could be used either not only in the neonatal intensive care unit or the pediatric intensive care unit, but all of the adult ICUs. So the device became a jack of all trades and a master of none. And I think it's made it more difficult for us to teach respiratory care to trainees. It's also a problem because so much of patient safety revolves around pattern recognition. And when everything is different, it's very hard to get somebody set in recognizing abnormal graphics or abnormal ventilator findings, abnormal blood gases. So I agree with you completely. And I think my institution did something really smart a number of years ago, and then dummied up again. But the smart thing was when they refitted the ventilator fleet, they said, we are only going to go with one ventilator, one conventional ventilator, to be used any place that ventilators are used in the children's hospital, whether it's the NICU, the PICU, the emergency room, the operating room, the recovery room, or the delivery room. And we want everybody trained on the same device. We want biomedical engineering to only have to deal with one device, one set of parts. And I think it worked great the first time. And then, as I said, as we got into more single platform devices and we discovered neonatal deficiencies or pediatric deficiencies, we went back to the old model. We now have 3 different devices that are in use in all of our pediatric units. And I think that people are rediscovering that it's difficult to teach and it's difficult to develop consistency when the products are all different.
Yeah, or at least when the names are all different and the products maybe doing similar things. It really is a case of creating confusion and increasing the risk of error. So from the manufacturing side, I can say that I've been a huge fan of Robert Chatburn's work and his desire to standardize on nomenclature so that at least we could communicate about the same effects that we're seeing. Now, Graham and I have talked a number of times about what you also really see. In fact, I had this discussion earlier today with a colleague. What you really see in the ventilator, if you instrument it and look at it, even on a test lung, would surprise you from what the user interface of the ventilator shows you. I mean, there are numerically, there are averaging elements that you should be aware of, the routines that cause smoothing of waveforms should be understood. And I'm a huge advocate of waveforms, having released arguably one of the first waveform products, and also having written the specs for the Bicor CP100 many moons ago, pulling that out of McGill University and Mike Goldberg under Millick's group. So that is one of the objectives we have in this group, is to try to, at least through example, use the terms that are acceptable. And I always keep an eye on Robert when he's joined the group, because he'll frown every once in a while when I'm describing a breath pattern or something. So, Melissa, do you have any questions? You certainly have a
Yes.
wealth of information here.
Yes, I'm curious, Dr. Dunn, how you saw the physicians trained in your institution as far as managing the individual patients and using waveforms, because I know waveforms is an area of interest for you. I've also done the textbook on waveforms. And I don't usually see physicians coming up and titrating individual patients by waveforms, more cookbook type settings. So what is your experience? Are you seeing waveforms used, and are you training physicians to titrate the ventilator individually?
Yeah, absolutely. You know, again, it's when you sit on the cutting edge, you want to make sure that the blade isn't pointing at you. But we work with the folks at Bird Medical to devise the first graphic monitor in the neonatal field. And it's every bit a part of ventilator management as are blood gases and chest x-rays. And I think the key part here is your RTs are really the champions of pulmonary graphics, because they're the most consistent people on the unit with respect to day in and day out respiratory management. So I agree that yeah, the short answer is yes. A key part of management.
Well, I know too that that's what a lot of the physicians are using for training. I just don't see them interacting with it as much. And a lot of times respiratory therapists are driven by what the physician is interested in. So even though the RTs are trained in it, we tend to respond to you. So I was curious if the physicians are interacting on that level or not.
Yeah. Well, in our unit, that's the case, but I know it's not the same all over. You know, and I can always tell when I come in the morning. You know, in the old days, the first generation devices auto scaled, so the graphs were always perfect. Now they don't. And when I come in and I see a pressure volume loop that looks like a pixel on the screen, I know nobody's looked at that ventilator screen all night.
Yeah.
Steve, just a curious question. I think you used to be a big fan of volume targeted ventilation, right?
Still am.
Still, thank you. That's the answer. And and it's a whole discussion again, I think. But also too, the big change in respiratory therapy, I believe, has been the advent of high flow oxygen therapy, right? Because all of a sudden, a lot of kids or neonates or, what have now the management's changed to high flow. Is that your agreement as well?
Yeah, it's been a trend, at least in the U.S. in neonatal intensive care units. But the problem that I see with it is well, there are a couple. Number one, the evidence base is negligible. Number two, what I have observed in my own unit is something that I call flow creep. Unlike using some other form of distending pressure, where you know exactly what you're giving to the baby, there's no way at present to monitor what kind of pressures you're generating. And I see residents and junior fellows treat the high flow device by just continuing to go up on flow rates. And I've walked in on occasions and seen a 600-gram baby who's recovering from necrotizing enterocolitis, a severe bowel disease, being treated with 12 liters per minute of nasal flow. And I just scratched my head saying, what are you trying to do to this baby? How much pressure are you generating? How much volume of gas are you putting into the gastrointestinal tract that just underwent significant surgery? So lots of questions. And I think right now the safety issues outweigh the efficacy issues.
I'm also starting to see some publications using high frequency ventilation non-invasively. Have you been using that, Dr. Dunn, and what do you think of its efficacy?
I haven't used it. It's an interesting concept, but I think I really wonder about patient comfort. I mean, somebody is blowing gas up your nose at 8 or 10 hertz. Hertz is the right word.
Yeah.
Yep.
It's true.
What impact do you think the resistance of the endotracheal tube has had on protecting babies from maybe some of our better intended therapies, the hub as a guard shield, so to speak, that resistor?
Well, it's kind of interesting. It's a challenge for us because we don't use cuffed endotracheal tubes. And knowing that the resistance is going to be proportional to the fourth power of the radius, what we try to do is find the largest tube that we can put in that still allows for a small air leak. So we know that we're not compressing the tracheal mucosa. The other issue is as the internal diameter goes down and the resistance goes up, turbulence becomes more of an issue. And I think of all the parameters, resistance is the one that neonatologists pay the least attention to.
Do you have any opinions, Dr. Dunn, about high frequency jet ventilation versus oscillating ventilation? It appears to me that oscillating ventilation is receding and jet ventilation is surging, even though the equipment is all fairly old.
I've always been a fan of high frequency as a rescue device and not a primary strategy. That's not to say there aren't units, and we all remember in the early days of oscillation, the stuff that came out of Utah, where you got put on the oscillator immediately after your umbilical cord got clamped. I think that each device has its unique advantages. And sort of, if I had to write a simple algorithm, I'd say if your primary problem is oxygenation, then probably high frequency oscillatory ventilation would be the way to go. If your primary problem is ventilation, I think the jet does a better job of CO2 elimination than does the oscillator. I think the jet works better with air leaks. Not to say that you couldn't treat an air leak with the oscillator, but it has additional issues. So And I think lung recruitment is probably easier to accomplish with the oscillator. And we use that almost exclusively to deliver nitric oxide.
Great. Thank you. I agree. Do you have any historical perspective? I'm going to ask one more question because this hit me now. I'm just, as you were speaking over time, since we've come full circle with the CPAP and how we're managing our babies now, I feel like I'm right back at the beginning of my career, and I'm sure you probably do as well.
Yeah.
I was involved in the very first surfactant studies, and I actually used that negative pressure box you showed. I hate to admit it as well. So what do you think about how successful we'll be going forward in this direction? Like, what do you see in the future for us in the NICU with this non-invasive as a primary support?
It may stick around for a while, but you know, as I said, I wrote an article with a colleague of mine not too long ago, and we published an issue of seminars called Myths of Neonatology or something to that effect. And the article we wrote was Myth: the neonatal mechanical ventilator is a relic. And I think that there is always going to be a need for mechanical ventilation. The studies of Hani Ali done a number of years ago suggested that the break point was 26 weeks, that more than 50% of babies less than 26 weeks will fail non-invasive ventilation in the first 3 days and will end up requiring mechanical ventilation. So you've got that population of babies. You've got another population who have inadequate spontaneous drive for whatever reason. Maybe it's pharmacologic suppression, maybe it's infection, maybe it's an airway or a pulmonary malformation. Got your post-op population, got your cardiac population. So it isn't going away. And the one thing that worries me the most is that if we go so far overboard with non-invasive therapy, there aren't going to be too many people around who know how to use a ventilator correctly.
Or know how to intubate.
That too.
Exactly. Thank you.
So this is non-related, but is the Real Seafood restaurant still in Ann Arbor, Michigan?
It sure is.
Okay.
Yep.
I was lucky enough to be part of ELSO many moons ago, and that was where we would love to go after Bob let us out.
It's kind of paradoxical, you know, coming to the Midwest and eating in a seafood place, but
Delicious,
It's
though.
kind of weird.
I think that's why people like it.
Jeff.
Yeah, thanks very much, Dave. Jeff Shaw here. I live in Christchurch, New Zealand, and I primarily work with adults. We have the occasional pediatric case that comes through, and the very, very occasional neonate, I guess, who comes in with bronchiolitis. I'm just thinking, reflecting largely on my adult practice, although I did spend a couple of years in a pediatric ICU in my early youth. But one of the issues that we struggle with in adults is consistency of ventilation. And we, I guess, believe that the answer to that might be in having computerized applications that assess the mechanical status or the status of the patient's lungs and recommend a particular setting that would be a peak recommendation and or a tidal volume recommendation, which might dynamically change. My question really is with neonates, because I've never worked in neonatal medicine, but in terms of recruiting lungs and looking at a spectrum of mechanical variability, interpatient variability in the neonatal sphere, is there a lot of it? And if there isn't, are you sort of more amenable to, if you like, a cookbook recipe approach where you say, well, you know, regardless, a neonatal lung will normally recruit once with one recruit maneuver, and then the rest of the time you don't need to worry too much about X, Y, and Z, and you just proceed along a certain pathway, versus a more bespoke approach, which says, look, we really don't know how this child's going to respond, but we think that the future ventilation in these children would be to use sort of adaptive algorithms that will be responsive and predict exactly what will be the best, what the patient response will be to particular settings. I hope I'm making myself clear. I just really want some sort of insight into what the world of neonatal medicine is like compared with adults, and the challenges that you have in heterogeneity of application of ventilation, and how that might be dealt with.
Yeah, thank you for asking that. It's a wonderful question, and I always have envisioned myself as the salmon swimming upstream with this, because I have always preached the individuality and the individualization of patient care. In the United States right now, everything seems to be moving towards protocolized care. And you know, the problem is the patients don't read the protocols. And I think the failure to match strategy with pathophysiology and the reassessment, the continuous reassessment of how the baby and the ventilator are interacting has led to not good things. And I've always preached that, yes, there are guiding principles, but you have to look at each case individually. There are so many confounders. Diseases are multifactorial. Patients are different. And if you treat, and the, you know, the example I give, this is a real life example. If you think about a baby with respiratory distress syndrome, the main pathophysiology here is loss of lung volume and atelectasis, diminished gas exchange. Think about a baby who has meconium aspiration syndrome. That's usually a large term or even post-term baby whose lungs are hyperinflated and has large lung volumes and a higher FRC. And if you treat those two babies the same way, you're doing at least one of them a disservice, if not both. And I think that it's been a hard message to teach. It's been a hard thing to say, this population is very heterogeneous. And even among babies with the same disease process, their response to what you do is going to be different. So you have to think individually. You have to design a strategy that takes into account what's going on with the individual patient.
Oh, that's very interesting. Do you think that the strategy at the moment is largely an art? That is, you know, what you've learned from all your years in this area, and what I've learned from my own experience. But at some stage in the future, we're going to be handing that art over to a machine, a black box, if you will, that will advise us better how to manage the patients. Do you think that is where neonatal ventilation might be heading?
Possibly. You know, it's hard to, what's that famous line about Yogi Berra, who's a famous American baseball player and a amateur philosopher who said things like, you can observe a lot by watching. But he also said something like, the future is hard to predict.
Yeah.
And I think, you know, who knows? I mean, look in the span of the lecture that I gave, just since 1960, all the things that have happened. I think the issue is what will be the driver.
Yeah, it's very good. Well, thank you very much for those comments.
And by the way, if you run into my good friend Brian Darlow, say hi to him for me.
Oh, I will. Yes, I know Brian.
Okay.
I'm most grateful to Professor Donn. It's a really, really interesting talk, and I've enjoyed how much in my earlier days of learning, I did have experience working with neonates and also in the laboratory, doing a perfluorocarbon and high frequency oscillation. So, and I'm very, very aware of two things. One is that how much the adult world, I work in the adult intensive care now, how much the adult world has picked up so many valuable lessons of CPAP leading on to PEEP, leading on to recruitment. And secondly, your comment that things have come in a cycle, they will come back again when they have been thought about in the future. Thank you very much, Dr. Donn.
My pleasure.
Okay, thank you very much, Professor Donn. On the East Coast, it is approaching nighttime for sure, bedtime for sure. But if we have any more questions, it'd be great to. So I'm looking forward to having you join us again. I want to thank Abraham as well as Melissa for joining us. And then the rest of the team, thank you so much. Everyone stay safe. We're hopefully getting close to being out of this stuff, and take care.
Thank you. My pleasure. Hope to do
Thank
it
you,
again.
Dr. Dunn. Thank you, Dr.
Thanks.
Dunn.
Thank you,
Thank you,
Dr.
Dr.
Donn.
Donn.
Thank you.
Thank you, guys. So thank you again. I think I'll finish this by saying go blue.
Go blue.
All right. Thanks, everyone. Appreciate it.
Bye,
Bye-bye.
everybody.
Thank you. Bye.
Cheers.